Well, good morning or good afternoon, colleagues, and welcome once again to the AU3S Capacity Strengthening Training Programme. This morning, we will be concluding Module 3 on risk assessment, where we'll be looking at the role of pharmacoepidemiology and regulatory decision-making. And I'm pleased that we are joined by two experts from the MHRA, Craig Allen, who's a senior pharmacoepidemiologist at the MHRA team, and Catherine Ord, a benefit risk unit manager, and they'll be taking us through this morning's session. Next slide, please. So you'll probably be familiar with the functionality of Zoom, but it's always worth the reminder. We have a Q&A box, and that will be used to pick up any questions that are raised throughout the discussion this morning, throughout the webinar. Please enter at any time any question that you have. The chat box should only be used when there are technical issues that you want to get across to the moderators. Everyone will be on mute, and the hand raising function, I'm afraid, will not solicit a response. Please use the Q&A box. Next slide, please. As always, we're joined by colleagues across the African Union and different stakeholders. The countries that we're predominantly working with are Ethiopia, South Africa, Nigeria, and Ghana, but other stakeholders involved in capacity strengthening in the African Union also join and are most welcome. So as mentioned, we've been going through a modular approach to this capacity strengthening. We're now bringing today benefit risk assessment to a conclusion. Next month, we'll be moving on to safety communications, and then in May, dates to be confirmed, we'll be looking at the role of expert advice and the running of expert advisory committees. So today's session, as always, is being recorded. We would encourage you to share the recording with colleagues. We're aware that there was a time change due to UK moving from Greenwich Mean Time into British Summertime. So some colleagues were unable to attend now this morning because of that time change. So the recording will be made available, and we'd encourage, as always, you to notify colleagues of that recording. I think today's session is going to be really interesting and thought-provoking. Next slide. So the aims, we have covered the high-level overview of risk assessment. We've looked at the understanding of risk management plans and risk minimization measures, particularly with a look at vaccines. We've looked last week at the principles of the periodic safety update reports. And then this morning, we'll cover these last two bullet points on pharmacoepidemiology and pharmacovigilance, and the different regulatory options that are available to us. So without further ado, I will hand over to Craig Allen. As I said, Craig is in the Vigilance and Risk Management of Medicines team as a senior pharmacoepidemiologist. Craig, over to you.
Thank you, Mick. Can everybody hear me?
Yep, that's clear, Craig. Thank you.
Okay, thank you. Okay, if I have the next slide, please. So my name's Craig Allen. I work at the MHRA in the pharmacoepidemiology team. I've been at the MHRA for about 9.5 years. It's a pleasure to be here today. So I'm going to give you a quick overview of the epidemiology team and what our role is within the MHRA, and then go on to talk about the value of pharmacoepidemiology within pharmacovigilance, and then give some examples of how we use epidemiology and epidemiological methods, particularly with regards to vaccine surveillance, signal strengthening and evaluation. Then I'll go on to talk a little bit about drug utilisation studies, how we look at the impact of regulatory action, and then give some examples from the using the HPV vaccine and the MenB vaccine. Next slide, please. So we're quite a small team at the MHRA. I think there's about 7 epidemiologists, and we get involved in a range of activities. So we get involved with signal detection methodology and research. So looking at how we can use the yellow card reports, the spontaneous adverse event reports that we receive, and we get involved with all the kind of methodology around the signal detection processes for that. We also get involved with signal safety assessment. So we might look at data that comes directly from drug companies through post-authorization safety studies, or those that are kind of published in the literature, and we'll get involved in reviewing those. We also conduct our own research to look at signals and evaluate them. So we use data sources like the Clinical Practice Research Data Link, which the MHRA hosts, and we do our own research using that database. We also conduct drug utilization studies to look at the wider use of drugs in the population, so we can kind of get a handle on how many patients are exposed to a drug. We also provide training such as this. We also give talks to universities and students to give them an overview of our kind of regulatory perspective, and we also get involved in providing scientific advice to drug companies if they request it. Next slide, please. So pharmacoepidemiology is really important. You'll probably be aware that in clinical trials, they're conducted in clean populations, and they're not generally powered for safety outcomes. It's usually to look at efficacy outcomes. So you can't always kind of detect adverse events in a clinical trial. So, and there's also a gap usually between the types of patients that are treated within a clinical trial compared to those that actually receive the drug in the real world, and they can be quite different. So our knowledge can rapidly change once a drug gets onto the market, and that gap can grow. So epidemiology is really important for being able to understand how drugs are used in the real world and the populations that receive them. So we need really good data sources to be able to do that. Next slide, please. So vaccine pharmacoepidemiology is obviously quite topical at the moment. Sorry, I just got a message to say the sound's not very good. I'm trying to speak as loudly as I can, so hopefully you can.
Yeah, I just answered that because that came through. Apologies, Annalene. It's very clear at my end. Possibly it's your Wi-Fi signal, possibly. There doesn't seem to be any audio issues, at least with myself. I don't know, Tyra or Mercedes, are you getting a clear sound?
I can hear everything clearly as well.
From my side.
Okay, so I'm afraid, Annalene, it must be a signal issue. Okay, so Craig, hopefully Annalene will get a stronger reception, and you carry on. Thank you.
Okay, all right, thank you. So for vaccines, the issues around these in terms of epidemiology are kind of perhaps a bit different, particularly because vaccines are mostly given to people that are healthy. And so they might have a lower tolerance of the risks, of the potential risks associated with them. And obviously the public perception of the benefits of vaccines can sometimes be quite low. And this can affect the success of the immunization program as a whole, and ultimately affect herd immunity later on, and then the longer term benefit of vaccinations. So obviously in the past we're aware that media coverage can have quite a big impact on the success of vaccines, and an example of this is the MMR vaccine and the risk of autism, and subsequent studies showed that that there was no risk, but this did kind of obviously have an effect on this vaccine. And also vaccines tend to be given to a large proportion of the population, so we need to be able to provide reassuring data and evidence that vaccines are safe. And so epidemiology has a crucial role in this. Next slide, please. So just to give you an overview of what epidemiology can teach us, it can allow us to understand the disease process and get a handle on the demographic profile of those patients who are exposed or unexposed to the drug of interest. We can also get an understanding of comorbidity and co-medication patterns. This is obviously quite important, particularly if we want to get an understanding of the potential role of confounding by indication, which can sometimes, well, usually does affect pharmacoepidemiological studies. So a patient's underlying kind of disease and comorbidity might bias our results. So we kind of need to get an understanding of that. It also allows us to explore the safety and efficacy of a drug in the real world and put the data that we get from clinical trials into context. Also, if there's any changes in the use of medicines over time, if there's any kind of regulatory actions which might affect how a drug is used or prescribed, which can obviously alter the benefit risk profile of a drug, we can conduct studies to do that, and such as drug utilization studies, and that allows us to get an understanding of how any kind of regulatory action has impacted that. Next slide, please. So again, just to highlight the challenges, particularly for vaccine pharmacovigilance, they tend to be given to a large proportion of the population, and they're usually generally healthy. And this can generate a large volume of spontaneous adverse reaction reports that agencies like the MHRA have to deal with. And because a large proportion of the population are being exposed to a vaccine, it's inevitable that some conditions might arise, some adverse events might arise in close temporal association with the timing of that vaccine. And so, this can present challenges. And because when a vaccine gets rolled out, it's generally quite quick. And so we need to be able to identify potential risks quickly and try to then distinguish between coincidental events, which might normally occur from those true adverse events. Next slide, please. So just to go on to post-authorization safety studies. So these are studies which are usually conducted by drug companies at the request of medicines agencies. And so they're generally conducted to further our understanding of a drug, get an understanding of the safety profile, and further quantify safety hazards which might have arisen in clinical trials. And so I've just summarized the main aims of past studies here. So they can be used to quantify a potential hazard or risk, gather further data on risks in specific populations, such as patients with renal impairment, because they might have been excluded from clinical trials. You can identify risks over a much longer period in post-authorization compared to in a clinical trial. They can also be used to provide reassurance on the absence of risks as well. If pre-authorization we identify a potential risk, a study can be conducted to provide reassurance that actually that risk is not something to be concerned about. We can look at patterns of drug utilization as well. So as I said, once drugs get onto the market, the populations that receive them can be quite different. So we can get an understanding of that. And these studies can also be used to measure the effectiveness of any risk minimization activities which might occur. Next slide, please. So just to give some more detail on what insights past studies can provide. So we can look at patterns of use, look at drug trends in drug use over time, and how these change. and also whether the introduction of a new drug, whether that has any effect on other drugs in the class or a similar class, and what impact that has. We can also look at drug dosage and duration of use, get an understanding of the patterns of how drugs are prescribed, and also what the determinants of those of drug use. So we can look at patient characteristics and the indications for that use. Sometimes we can look at off-label use as well, if that is of a concern. We can also use data to look at to try and assess the understanding of and awareness of contraindications and how drugs should be prescribed according to clinical guidelines. And we can also look at the risks of adverse events as well. So we can, design studies where we've pre-specified an adverse event and then look at the trends in the incidence and prevalence of that adverse event over time. And then we can use that to try and determine whether there is a causal association between an adverse event and the drug of interest. Next slide, please. So at the MHRA, we routinely use something called observed versus expected analyses. This is used particularly for vaccine studies, and it's usually implemented as an enhanced vaccine signal detection tool. And it's really useful because it allows us to rapidly identify whether there's any kind of potential excess reporting with regards to spontaneous adverse event reports that we received through the yellow card scheme, for example. And it allows us to provide reassurance when the observed number of adverse events that we receive does not exceed those that we would normally expect in the background population. So it can be used on a weekly basis as we receive data. So it's really useful in providing that real-time active surveillance. And we can also pre-specify at the outset what adverse events we're interested in. And it allows us to strengthen the signals that we receive. So we can provide a snapshot on a regular basis to see whether the observed number of events is higher than we would expect in the background population, and it also complements the data that we receive through the analyses that are done as part of the disproportionality analyses, which are also conducted. Next slide, please. So to conduct these types of analyses, we need data from a range of sources. So the observed number of reports we receive are generally from the spontaneous adverse reaction reports we receive through things like the yellow card scheme. It can also be through data obtained through routinely collected electronic healthcare records, such as the Clinical Practice Research Data Link, which we use at the MHRA. And then the expected number of reports is what we would normally expect to see in the background population. So we can get that from data sources such as literature or electronic healthcare records as well. But to do that, we also need to know how many vaccines have actually been administered in the population. And because spontaneous report, there's always a level of underreporting when it comes to spontaneous adverse event reporting, we can conduct sensitivity analyses to model the different levels of potential underreporting to provide reassurance regarding the observed count. Next slide, please. So the method that we use at the MHRA is the maximised sequential probability ratio test, the MaxSPRT, and this is used on a weekly basis to monitor vaccines and adverse events that are coming through. And the observed expected ratios are converted to a log likelihood ratio, and then it's compared to a critical threshold from a Poisson distribution. So once the observed number of events exceeds the expected and that critical threshold is reached, that may then signal that there is a that there is a signal. So we can then conduct further studies to kind of look at that and delve further into the data. And because this type of approach is conducted on a regular basis, we have to adjust for multiple testing of the p-values. So the methods, the MaxSPRT method allows for adjusts for multiple testing. And I've just given a reference at the bottom there, which provides further detail on this method, if anybody's interested. Next slide, please. So just to give an example of how we've used this method, in terms of a vaccination campaign. So the example I'm giving is for the human papilloma virus vaccine. It's called Cervarix, and this was first introduced in the UK from September 2008. And at the time, all adolescent females aged 12 to 13 years were offered the vaccine, and this amounted to over 300,000 girls each year. And there was then an additional catch-up campaign to also vaccinate girls in older age groups, in the 14 to 18-year-old age group. So this amounted to about 1.5 million females. And because the UK was the first country to use this vaccine in the national immunisation programme, it was really important to get to conduct studies, to conduct observed expected analyses, to provide some reassurance on the safety profile of this vaccine. Next slide, please. So to conduct this piece of analyses, we obtained background data on the incidence rates for pre-specified adverse events which we were interested in over a 10-year period, and we used the clinical practice research data link to obtain that data. And the adverse events that were pre-specified were Guillain-Barré syndrome, facial palsy, chronic fatigue syndrome, and encephalitis. So the example I'm going to give later on will focus on the chronic fatigue syndrome events of interest. And we calculated age and gender specific rates of the background rates, and these were selected based on those which are naturally occurring in the target population, and they were most likely to be reported as adverse events close to the time of vaccination. Next slide, please. So during this vaccination campaign, we received 8 cases of chronic fatigue syndrome in girls aged 12 to 13, and then 1 case in those aged 17 to 18 years. And then in the following year, we received 9 cases in the 12 to 18 age group. And you can see that there were media reports of chronic fatigue-like symptoms in the media. So it was quite important to obviously look at this and provide some reassurance to the general public. Next slide, please. So this graph shows results from the observed expected analyses using the MaxSPRT method. So the x-axis along the bottom shows time, so that's over the course of a year, the 52 weeks of surveillance that were carried out. And then the y-axis shows the log likelihood ratio. So that's the observed to expected ratio. And then these different coloured lines show the different levels of underreporting of the spontaneous adverse events received. And this horizontal line in bold here is the critical threshold, that's obtained from a Poisson distribution. And so basically this graph kind of shows that we seem to show a signal when there were about 10% of adverse events reported. So when there was about, say, 90% underreporting of adverse events. And then we also looked at 25%, 50%, 75% and 100% level of reporting. And as you can see over time, this signal was not sustained, and it and it was below the critical threshold. So that provided some reassurance to us. It's also quite important to note that chronic fatigue syndrome is quite a difficult condition to diagnose, and it can take several months, up to a year even, for this condition to be diagnosed by doctors. So so obviously over time it's reassuring to show that this signal was below the critical threshold. Next slide, please. So the observed expected analyses indicated that the levels of reporting for chronic fatigue syndrome were within the expected levels, and this enabled the MHRA to provide rapid reassurance in response to the media attention. But the observed expected analyses are limited in a way in that they only can be used as a signal generating or signal strengthening tool, and they don't allow us to establish causality between the vaccine and an adverse event. So it's essential to conduct further epidemiological studies to further provide reassurance regarding this signal. Next slide, please. So just to highlight the strengths and limitations of these observed versus expected analyses, it is a really robust method of signal detection that complements the disproportionality analyses which are conducted. The expected rate, so that's the background rate, is not affected by reporting biases, which can affect the observed rate. And these methods allow us to make adjustments and model the levels of underreporting which spontaneous adverse event reporting can be subject to. And it's well suited for vaccine safety surveillance following the introduction of a new vaccination program, because obviously patients within the population are rapidly exposed to a vaccine. So we can, as data comes in on a weekly basis, we can monitor that quite closely. It does have some limitations, obviously, as all statistical methods do. It does rely on the data coming in to be accurate. So we need accurate numbers on obviously the background rate, and also the levels of exposure in terms of how many patients are actually receiving the vaccine in the population. And these methods can't be used as a data mining method. They can only be used for pre-specified conditions at the outset for signal strengthening. Next slide, please. So once we've conducted these observed versus expected analyses, we will then go on to further evaluate signals through observational studies. And these can be cohort and case control studies, or we can use self-controlled case series designs, which are especially useful for vaccines. So a self-controlled case series just uses the patients who have received the vaccine, so there's no external control, and the patients receiving the vaccine act as their own control. And essentially this method just compares a period following vaccination called the risk window, and compares the adverse events occurring within that risk window compared to control periods. So this can be periods prior to the vaccination. We can also use ecological analyses. So these are this looks at trends in the incidence of adverse events over time. So you can compare once a vaccination campaign occurs, you can compare the incidence of adverse events before and after to see whether there's been any change in the incidence of the events of interest. And we can use a range of different data sources to conduct these observational studies. So we can use data from primary collection methods, so those that are specifically collected for the study, or we can use routinely collected data that already exists. So in the UK, at the MHRA, we regularly use the CPRD data to conduct these studies. We can also request studies from drug companies as well, to provide some reassurance on signals and adverse events. Next slide, please. So just to give an example from the HPV vaccine again and chronic fatigue syndrome. So to further evaluate the signal, an ecological study was conducted by colleagues. So the reference is there at the bottom. And so as part of this ecological study, the incidence rates of chronic fatigue syndrome among girls aged 12 to 20 during the 11-year period were compared. And this was for the period both before and after the introduction of the HPV vaccine, and a Poisson regression was the statistical method used to do this. An analysis was also conducted in adults aged 21, over the age of 21, and boys aged over 12 to 20 to see what impact the vaccination had on the outcomes of interest. Next slide, please. So this graph just shows the trends over time in chronic fatigue over this 11-year period in girls and boys and adults. So as you can see, overall, the trend kind of indicates that there was a general decline in the incidence of chronic fatigue syndrome. Next slide, please. So during the 11-year period, there were nearly 1,300 incident diagnoses of chronic fatigue syndrome in girls aged 12 to 20. And when we compared the incidence of this rate, both in the period after vaccination, sorry, in the period before vaccination compared to after the introduction of the HPV vaccine, the incidence rate ratio was 0.94, and you can see there that the confidence interval included 1. So this indicated that there was no statistically significant difference in the incidence of chronic fatigue syndrome in the period after the vaccination compared to the period before the introduction of the vaccine. So that provided really reassuring evidence. Next slide, please. So a self-control case series study was also conducted as part of this, so to further examine the potential risk of chronic fatigue syndrome. As I just said previously, a self-control case series only uses the cases in the study, so it's really good in that respect, in that you don't need to find external controls because the cases act as their own controls. And it's also good because it automatically, due to the nature of the study, controls for all time invariant confounders. It won't obviously control for potential confounders that change over time, so you will still need to adjust for that in the model. And this diagram at the bottom just basically just shows the diagrammatically the design of the study. So you can see here in the middle that when the vaccination occurs and the risk window. So a risk window is predefined. So that's the period where you think an adverse event might most occur, and then you then look at the control periods either side of that and compare the incidence of an adverse event in the control periods compared to the risk window period. Next slide, please. So the risk of diagnosis of chronic fatigue syndrome in the year after the HPV vaccine was estimated relative to the risk in the remainder of the follow-up period. Sorry. And So a 12-month, for this particular outcome, a 12-month risk window period was defined post-vaccination. And age and calendar time were deemed to be time-varying confounders, so they were adjusted for in the multivariate model. And as part of this, sensitivity analyses were also conducted, and this included looking at referrals to secondary care for chronic fatigue syndromes to see if that changed the measures of effect, and also the risk window period was also changed from 12 months to 6 months, and also 18 months to see if that had any effect on the outcomes. Next slide, please. So 187 girls with a new diagnosis of chronic fatigue syndrome were included in the study. And when the incidence rate ratio was calculated from the Poisson regression model, this was calculated to be 1.07 with a 95% confidence interval of 0.57 to 2. So it includes the null of 1.0. So this provided evidence that there was no increased risk of chronic fatigue syndrome with the vaccine. Additional sensitivity analyses, which I just mentioned, were also conducted, and this didn't show any associations with regards to chronic fatigue syndrome. Next slide, please. So just moving on to a second example of the MenB vaccination and risk of seizures. So this was published. The references there at the bottom for you. So as part of this study, an ecological study was conducted, and this compared the incidence of seizures in the 5-year period before vaccination and in the 20-month period following vaccination, following introduction of the MenB vaccine into the routine childhood schedule. Data from the CPRD on seizures was obtained within the 7-day period post-vaccination, within the 7 period of vaccination, and at 12 months of age. And the temporal trends in the incidence of MenB was analysed using a Poisson regression model, and then sensitivity analyses were also conducted post-vaccination. So this was at 3 years and 4 months when the MenB vaccine is not given, to see if that had any impact on the results. Next slide, please. So when we looked in the CPRD, 32, 16, and 92 incident seizures were found in infants aged 2, 4, and 12 months respectively across the whole study period. And so incidence rate ratios were calculated for each of those age groups. And you can see here that the confidence intervals all include 1. So this indicates that there was very weak or no evidence of an association between the MenB vaccine between the MenB vaccine and risk of seizures. So this provided reassuring data. Next slide, please. So just to conclude on these particular methods that we use for vaccine pharmacovigilance. The nature of vaccine pharmacovigilance requires methods to be able to rapidly evaluate emerging safety signals, because obviously vaccines are given out en masse, and large proportions of the population are rapidly exposed to a vaccine. So we need to be able to distinguish between true adverse events and those that are kind of coincidental and just occur generally due to chance in the in the background population. So observed versus expected analyses, as I've demonstrated, are really useful for that. But to be able to further kind of characterize the signal and provide further reassurance on signals, it's important to conduct robust epidemiological studies. So as you can see from these two examples using HPV and the MenB vaccines, multiple statistical approaches are really useful and important in allowing us to establish safety both proactively in real time and then retrospectively later on as more patients are exposed to a drug and we have follow-up time accruing in those patients. And we've now embedded these observed versus expected analyses into our vaccine pharmacovigilance programs at the MHRA. Next slide, please. So just to move on to drug utilisation studies. So we also conduct these routinely at the MHRA. And these are really important for looking at prescribing trends over time. And they're really useful for looking at safety concerns and the impact of regulatory action and the effect that any kind of media reports might have on the use of a drug in the population. So if the MHRA takes regulatory action against a drug, so this could be warning healthcare professionals and patients about a potential adverse event, we can conduct drug utilisation studies to see if there's any impact not only on the drug of interest but also on other drugs in the class, because often there might be, if there's, for example, been a contraindication for a drug of interest, we might find that there has been a change in other drugs, on the prescribing of other drugs in the class. So it's really important to look at that as well. Next slide, please. So as a regulator, it's really important to look at the impact of regulatory action and the effectiveness of risk minimisation measures. So that we do conduct these studies routinely. So there's a reference at the bottom there on a study which I published back in 2017 on the co-prescribing of on the impact of regulatory action on the co-prescribing of renin-angiotensin system blockers in UK primary care. So I used the clinical practice research data link to do that. So these risk minimisation effectiveness studies are useful for looking at the effectiveness of restrictions on the indication and the communications which the MHRA might communicate on a safety concern to patients and healthcare professionals, and also to look at the impact of risk minimisation measures in the population. If also there's been a requirement to take a drug off the market, so because of a very serious safety issue, we can then look at the impact that that's had on other drugs in the class, or alternative medicines that patients might have been switched to, because obviously you would expect to see an increase in those drugs when those patients are switched. We can also look to see whether the any changes in the product information or clinical guidelines for a particular medicine, and whether these are being adhered to by not only patients but also healthcare professionals. So if there's been a contraindication, we would expect to see a decrease in the prescribing of that drug to relevant patients. If there's been any communications about a safety concern, as I've said, we can look at what impact there has been on prescribing or switching to alternative treatments. and also if there's any risk minimisation measures. So if patients are required to have regular tests, so for example, liver function tests, we can look to see in databases like the CPRD to see whether healthcare professionals are adhering to that. Next slide, please. So just to conclude, pharmacoepidemiology is really important in pharmacovigilance. As I've said, when a drug is released onto the market, when a drug is released onto the market, the knowledge gap between the clinical trial data and real world use can grow quite rapidly, and so it's important to conduct these studies to get a handle on that. As I've demonstrated, we can use observed versus expected analyses, ecological studies, and the traditional observational study designs such as case control, cohort, and self-control case series designs to further characterize a safety signal and provide reassuring data on the safety of the medicine. And obviously, as a regulator, we want to ensure that the regulatory action that we're taking is actually having the desired effect. So we can use these methods and studies to monitor that impact. Next slide, please. I think that's it. So I'll finish there, and we can move on to Catherine's talk. Thank you.
Thank you, Craig. If everyone's happy for me to continue, I will. So my name's Catherine Ord. I've mostly been an assessor at the agency since I joined in 2004, although from time to time I have been a unit manager, as I am now managing a team of assessors. Next slide, please. Today I'm just going to talk to you about regulatory decision making. I'm going to talk about at what points in the product life cycle we make regulatory decisions and how we go about making these. I'll go over the different regulatory options with some real examples of these from the UK. I'll talk a bit about when to seek advice from experts and what help experts can provide, and finish off with some information about implementation, communications and evaluation, although I'm not going to talk too much about communication because we've got a dedicated session on that in a couple of weeks' time. Next slide, please. So when we talk about regulatory decision making, really what we're really talking about is benefit risk assessments when it comes to medicines and vaccines, and these are the basis for regulatory decisions. So there are three main stages of the product life cycle. So there is the research and development stage, there is the point at which the product receives its license and gets marketing authorization, and then there is the post-authorization part of the product life cycle. So regulators actually have very minimal involvement in research and development. Our role there is generally advisory, and we don't really make decisions about benefits and risks at that stage. What we do is provide advice to companies through meetings. We provide assistance with developing protocols and support for paediatric development, but we don't really make decisions at that stage. The first time that we really make a decision about benefits and risks and really put some decision making into practice is at the point where the product gets marketed. So depending on the quality of the data provided and how reassuring evidence of efficacy is, we may grant a license for that product. And this might be a full license, or it might be a conditional license if, for example, we don't quite have as much efficacy data as we might like, but we were expecting more from the company. Then that would be when we give a conditional license. Or if it's a medicine which is going to be useful for some patients, but where it's a very limited population and we're not going to expect much more in the way of data, we might grant a license under exceptional circumstances. Really though, for most products, the post-authorization phase is where most of the use of the product will occur. As Craig's mentioned, in clinical trials, it's a fairly limited patient population, perhaps only a few thousand people exposed. So really, once a product gets marketed, that's when you really start to see use of the product. and real life use of the product. So in clinical trials, use is very heavily monitored. And in real life, of course, people don't take medicines as directed. They might take them with other medications. They might be used in a completely different population to those that were seen in clinical trials. So for all sorts of reasons, the post-authorisation phase is really important and is generally the most important part of a product's life cycle. So in the post-authorisation phase, we constantly assess benefits and risks. And I'll talk a little bit more about that in a moment. Next slide, please. So at the time of licensing, we're basically looking at efficacy, safety and quality. So we want to be assured that the product works. So this is generally done using clinical trials. We would hope that these would prove that the treatment is superior to placebo and is at least as effective or is non-inferior to an active comparator. On the safety side, we look at preclinical studies, so that's studies in animals or studies of pharmacokinetics, as well as clinical studies. And generally, we would expect to see that the risks of the product are outweighed by the expected benefits of treatment. And there it's important to consider a comparison with active comparators. So generally, the active comparator is a treatment which is already in use, where we know lots about how well it works and how safe it is. And by comparing a new treatment against that, we can get a very good idea about what the likely balance of benefits and risks is going to be. We also take quality into consideration. It's important that products meet acceptable quality standards, and that's an important part of the licensing pathway. Next slide, please. Post-licensing, it's more of a continuous process. Very rare adverse drug reactions might only start to be seen when the product is used in a very large number of people. We may start to see side effects which have a very long time to onset or which happen after the product's been used for a long time. And we might find that the balance of benefits and risks is less favourable in certain subgroups of patients, including those who may not have been studied in clinical trials. It's also likely that as a product gets used in practice, we see medication errors where people don't use the product as directed, and that leads to problems. And we may also see drug interactions where the product is used with other medications that weren't studied in clinical trials. So for all these reasons, there is a continuous re-evaluation of the balance of risks and benefits. So this can arise because of signal detection, because of new data from clinical trials, because of new safety data from observational studies of the type that Craig has described. There might be new literature sources which provide information about safety, or safety concerns for other drugs in the class which might also apply to other products. But we do tend to perform a bit more of a formal assessment of benefits and risks at defined points in the product lifecycle. So in periodic benefit risk evaluation reports or PSURs, any extension of the license, whether that's a new indication or a line extension, so a new formulation. We do it at renewal of the license, so every 5 years the license gets renewed. We will do it at annual renewals for conditional marketing authorizations, or the annual reassessments for those granted under exceptional circumstances. If there's any change of legal status, we'll look at benefit risk, and also as part of any major safety review or referral. So in all of those types of procedure, there will generally be some kind of statement that the balance of risks and benefits is unchanged or continues to be positive. At least that is if there aren't any problems with the product. Next slide, please. So when we're talking about decision making about benefits and risks, I've included this diagram just because this is like an overall illustration of what benefit risk really means. So what we ideally want is a product that has lots of benefits and very few risks. Unfortunately, that's not always the case. Sometimes there are lots of risks with a product for relatively little benefit. You might have to click on the slide actually. I think there's a red circle that should appear. Yes, there it is. So this part in the middle, this is where things get a bit tricky, because where the balance of risks and benefits is a bit in the middle, it's difficult, and you might need to apply a more complex judgment or assessment in that situation to try and work out how can we maximize benefit and also minimize risk. Next slide, please. So it's fair to say that most regulatory decision making is done on a fairly informal basis, and it's quite subjective. So efficacy we tend to think of as being almost a given because it's been shown in clinical trials. So it's more usual to actually get new information about risk or safety concerns as the product gets used more widely. So when we think about risks, we can describe these in terms of their seriousness, how long they last for, how severe the reaction might be, how commonly it occurs, and whether they're only seen in certain types of patients or at certain doses. When we think about benefits, we usually consider the seriousness of the condition that the product is being used to treat, whether it's a chronic condition and is going to be used on a long-term basis, and whether the product is used to prevent, manage or cure a particular condition. And lots of thought and effort has gone into whether more formal methods of measuring benefits and risks can be applied, try and sort of pull us away from this more informal approach. Next slide, please. So I'm not going to go into too much detail about the things on this slide. You can go away and have a look after this talk if you're really interested. Essentially, these fall into two broad camps. These are qualitative approaches and quantitative approaches. So when we're talking about qualitative, it's really a more sort of structured approach to pulling together information about benefits and risks and any uncertainties about these. So the PRO-ACT model is one of the more widely used ones, as is BRAT. When we're talking about quantitative methods, we're talking about essentially trying to put a number on benefit risk, which is quite difficult. So this might rank products or put them on some kind of scale. You might have seen these types of approaches used before, particularly number needed to treat and number needed to harm gets used quite widely. But neither of these approaches has really been very widely adopted, even though they've been discussed quite heavily. Next slide, please. It is worth mentioning that the US Food and Drug Administration do use a benefit risk framework in the presentation of their assessments about benefits and risks. So they pull together information about the condition, the current treatment options, and the benefits of treatment, as well as risks and risk management, not only in terms of the evidence for these, but also the uncertainties. Next slide, please. Similarly, the European Medicines Agency uses what's called an effects table, which pulls together a summary of the evidence of efficacy and unfavourable effects, as well as uncertainties about these and the strength of evidence. So you'll see a table like this in every public assessment report that's published by the European Medicines Agency, sort of at this point. The particular example I've included here, just for you to see, is for remdesivir for the treatment of COVID-19. However, even using these formal methods, expert judgment does still play a major part in decision making. Next slide, please. So what is the decision making process? So it ultimately boils down to whether the benefits outweigh the risks. And we can use the methodologies that I've talked about, but this doesn't really happen much in practice. What generally is key is the experience and judgment of assessors, as well as the input and advice that we get from experts. Now, sometimes it's very difficult to make a judgment about benefits and risks, and essentially, if we're not really sure, or if it's kind of a bit in the middle, we generally apply the precautionary principle. So if we were concerned about the balance of risks and benefits being, dangerously close to being not positive, we would generally take a precautionary approach and restrict use in some way just to protect patients. We wouldn't generally wait for more information before making a decision. We'll always consider how best to maximise benefits, and where we can, we try to identify who is at risk of harm and any actions that could be taken to minimise the risk of harm. We will also try to explore what options there might be for further investigation or collection of information about safety. Next slide, please. So moving from making a decision to taking action. So which regulatory options choose? And it really depends on what you're trying to achieve. So you might have identified there is a new risk that wasn't previously known about, and it's a case of raising awareness about that. You might have determined that actually, although you've got some new information on risk, it's not necessarily different to what you knew before. So it might just be a case of reminding people about that. You might want to raise awareness of a known risk, perhaps some new information has come to light which has made it clear that some people just don't know about it, and there's more work that needs to be done to make sure people know. You might want to prevent use in some way, so either to prevent people who are using the product or certain people who are using the product from carrying on using it. You might want to stop prescriptions being issued to new users, so people who are using it okay with no problems now can carry on using it, but maybe you don't want anyone else to take it. You might want to limit use just to patients who are likely to derive the most benefit. You might have decided that there might be some need for patient monitoring, for example, monitoring their renal function or their liver function before, during and after treatment, which you want to include in product information or tell people about. Or maybe you just want to make sure that people who are most at risk of harm don't take the product. Next slide, please. So there's a few different approaches that we can take here, and we split these into two broad categories. So we talk about routine risk minimisation and additional risk minimisation. So routine risk minimisation is basically any changes to the product information, which is the information for healthcare professionals and prescribers, and the information for patients, as well as the product labelling. Pack size is also considered to be a routine risk minimisation measure, as is legal status. And two options that we can consider, which are considered to be routine, are to suspend the license or to revoke it, and I'll talk a bit more about those in a bit. When we talk about additional risk minimisations, these are really any measures beyond the routine measures that I've already talked about. So this could be educational materials for healthcare professionals and patients. This could be controlled access to a medicine or controlled distribution, the introduction of a pregnancy prevention plan, or a direct healthcare professional communication. I should also say that doing nothing is also an option, but we would generally consider, you know, almost like a rank from do nothing right up to revoke the license, and then everything in between. Next slide, please. So focusing first on the routine measures, when we're talking about amending product information, the product information is split into several different areas. So if we want to restrict the indication to those who get most benefit, we can do that. We might include new advice to reduce the dose if something happens, or to limit the duration of treatment, which will minimise exposure to the drug. We might want to contraindicate use in certain patients, or patients who have certain underlying conditions, or in certain patient populations, or use with other products. And this generally would prevent use in the most at-risk patients. We may want to introduce new warnings and precautions for use in particular situations, or new recommendations for monitoring. We might want to warn against interactions with other medicines, so either advice for lower doses, or for not using at all, or avoiding use, as well as food interactions. These can be quite important as well. We might want to include some information about pregnancy and breastfeeding, any effects on fertility, the fetus or the neonate. We quite often use what's called benefit risk statements, which generally is something like, you know, use with caution and consider whether the benefits of treatment outweigh the risks. And we also have a section describing the undesirable effects, which is generally where we would include information about newly recognised side effects to a medicine, or further information about a side effect which is already listed. Next slide, please. So turning to some of the other regulatory options, I've tried to include examples just to illustrate all of these. So sometimes we talk about label or box warnings. Certainly in the UK, we no longer really give our medicines in medicine bottles. We don't have a pharmacist who counts out tablets and dispenses them anymore. Most medicines come pre-packaged in a sealed, closed container with a set number of tablets or capsules if it's an oral medicine, or a certain amount of liquid in a bottle. So there's information you can include on the label, and it's particularly important that any information which is critical for patients to see is clearly displayed on that label. So the example I've included here is basically for opioids. So in 2019, we reviewed the risk of addiction and dependence with opioids, and we realised that many people weren't aware the medicines they were taking contained opioids, and weren't aware they could become addicted to them. So we asked companies to make sure that all opioids in the UK are now clearly labelled, and on the box it says contains opioids, can cause addiction. That wasn't the only thing we did. We also strengthened warnings in the product information, and we put out communications to relevant healthcare professionals, and that was supported by a press release. Next slide, please. Pack size restrictions are also a regulatory option. If you limit the number of tablets in a pack, not only does that limit how many tablets a patient can take. It also, in some situations, forces a patient to go back to their doctor to get a further prescription, and helps the doctor sort of keep an eye on how well the patient is doing. So pack size in itself can be a way to minimise risk. I've included an example here of pseudoephedrine, which is a decongestant used in lots of cough and cold medications. We recognised a few years ago that some people were misusing pseudoephedrine. Essentially, you can, if you know what you're doing, cook it up into crystal meth. So for that reason, in 2008, we introduced some restrictions on selling of pseudoephedrine in the UK. We thought about this very carefully, considered lots of different options, but ultimately the ones which most pharmacists preferred was that it remain available as a pharmacy medicine. You can buy it from pharmacies, but that's it. We restrict the amount of tablets available in a single pack, and also restrict how many packs can be sold in a single transaction, just to limit the possibility that people might misuse the product in this way. Next slide, please. Another regulatory option is a change of legal status. This is different in most countries, but in the UK we have 3 types of legal status. We have prescription-only medicines, which can only be given out with a prescription. We have pharmacy medicines, which can be sold from pharmacies under the supervision of a pharmacist. And we have what are called general sales list or GSL products. These are medicines which can be sold from corner shops, supermarkets, petrol stations, generally, retail outlets. And these tend to be products which are associated with a fairly low level of risk. Now, sometimes it's appropriate to reclassify medicines or change their legal status to minimise risk. Sometimes companies ask for a change in legal status if they're satisfied the product is safe and they want it to become available to a wider market. They can ask for that. Similarly, if we are concerned about safety, then we can restrict use, and we can essentially make a product more restricted by requiring a prescription, for example. I would include an example here of oral diclofenac. This was available as a painkiller for many years. But a few years ago, we recognised that actually it was associated with a very similar degree of cardiovascular risk to some of the coxib medicines. You might recall there was some controversy over those a few years ago. So for this reason, in the UK, diclofenac has been reclassified from a pharmacy medicine that you can buy from pharmacies to a prescription-only medicine because of this cardiovascular risk. Next slide, please. And in the UK, we communicated this to people through an article in our Drug Safety Update monthly bulletin, explained that this was no longer available as a pharmacy-only medicine and the reasons for that. Next slide, please. Another possible legal change is making a product restricted medical prescription. So this ensures that certain products can only be prescribed by certain types of healthcare professionals or in a certain setting. It's usually specialist use only, or only to be prescribed and used in hospitals. So the examples I've included on the screen here are all for products which are used for pharmacological cardioversion, essentially reversing heart rhythm disorders. And I've included the information which is in the SPC for amiodarone, flecainide and dronedarone. All of these products are used to revert heart rhythm back to normal, but because they can be associated with some fairly extreme side effects, it can make people very ill if they're not used properly. These can only be used by specialists in a hospital setting. Next slide, please. I've talked a bit about educational materials. These are also referred to as educational programs, and they are intended to educate professionals, healthcare professionals and prescribers about important information about safe use. Generally, these days, we would introduce them at the time of licensing. There will be an expectation that companies would provide them to all people who are likely to prescribe the medicine. We have been a bit more flexible about how these are sent out, particularly with the COVID-19 pandemic. We used to require that they were sent out in hard copy. So essentially, a copy would land on someone's desk. We're now being a bit more flexible in allowing these to be sent out by email or by electronic means. But the company retains responsibility for producing these materials. They have to be approved by the MHRA before they can be sent out. And they also have to agree with the MHRA a method of distribution and who will receive them. They do require careful consideration. It's very important that they're not promotional items. They are generally focused on minimising the risk of a particular safety concern. They are meant to be additional to the SPC and not just duplicate information from the product information. and they shouldn't introduce unnecessary burdens on either the prescribers or the companies in producing them. Next slide, please. So there are a few different types and formats of educational materials. So those aimed at healthcare professionals are generally in the form of a direct healthcare professional letter. There can be a physician's guide to prescribing or a pharmacist's guide to dispensing. Very often there's some kind of checklist that the pharmacist or the prescriber has to go through before they provide or prescribe the product to the patient. And for some products, there might be a specific training program. So perhaps an online course or video that prescribers have to agree to watch, or some kind of test they have to take to prove that they have understood the information being given. For patients and carers, there's generally not as much educational material as there is for prescribers, because for most medicines, the decision on whether or not to use the product lies with the prescriber rather than the patient. But it is important sometimes that patients get given materials directly. When it's intended that all patients should receive the materials, we try to ask companies to include what's called a patient alert card, which is a credit card sized piece of information which is inserted in the pack of medicine. This makes sure that all patients who get the product get a copy of the card. But there may also be patient information brochures or booklets, which are generally given by the prescriber to the patient rather than being sent to the patient directly. All of these materials can take different formats, either leaflets, booklets, cards, videos, websites. But whatever is put in place, it's generally agreed with the MHRA before it is sent out. Next slide, please. Also, sticking with additional risk minimisation measures, we have what's called controlled access or controlled distribution measures, and these generally limit access beyond routine risk minimisation, and it's usually a requirement that patients are registered in some kind of registry, that all parts of the distribution chain have agreed to register with the company so that you can monitor exactly who's getting the product. And they generally require some kind of condition for supply. So for example, you have to prove that you're not pregnant before you get the prescription, and again before the product is dispensed to you, or you have to provide the normal test results. So the example I've included is for clozapine, which is an atypical antipsychotic. It's very effective where other antipsychotics haven't worked, but it does have an associated risk of blood dyscrasia, as it can lead to very low white blood cell counts, which can leave you wide open to risk of infection and make you very poorly. So there is a centralised monitoring service, which basically all patients who are taking clozapine have to be enrolled in. They have to provide regular blood test results into that service to be allowed to carry on receiving prescriptions for that product. For clozapine, patients generally have their white blood cell counts checked at least weekly for the first 18 weeks, every other week for the next 18 to 52 weeks. And then if you're really stable after a year of treatment, then you would normally have your blood tested once a month. At any point, if your white blood cell count falls below 3 times 10 to the minus 9, you basically treatment is stopped. And there are 3 different Clozaril products in the UK, and they are all prescribed by brand just to minimise the risk of patients becoming stable on one product and then having their treatment disrupted by a switch onto a different brand. Next slide, please. We also have the option to put in place a pregnancy prevention programme. This will aim to minimise pregnancy exposure during treatment, and this is generally for products which are known teratogens but which are very useful. So I've included an example here for isotretinoin, which is a retinoid which is used for the treatment of acne. Again, an incredibly effective medicine, but it does carry very distinct risks of teratogenic effects. So it's very important that women of childbearing potential are enrolled in the pregnancy prevention programme. Now, this has 3 parts. It has an educational programme, which has all kinds of elements to make sure that physicians, pharmacists and patients are aware of the risk. There was an acknowledgement form for female patients to complete, and just to confirm that they've been warned about this risk and they're agreeable to it. There's a patient information brochure and also a brochure about contraception. The second element to this plan is therapy management. So as well as provision of educational materials to patients, patients have to have medically supervised pregnancy testing done before, during and 5 weeks after the end of treatment. And women have to agree to use at least 1 method of contraception, preferably 2, ideally using a barrier method for at least 1 month before starting therapy, continuing throughout treatment, and then also for a month after stopping therapy. There's also distribution control. So prescription of isotretinoin for women is limited to 30-day supply only, and each prescription is only valid for 7 days. So there's quite a lot of measures in place for isotretinoin just to make absolutely sure that women are not inadvertently exposed to this medicine, which might cause harm to their baby. Next slide, please. One of our options is to suspend the license. So we might have a concern about safety, and for that reason, we don't want to put any patients at risk of harm while we are investigating that further. A recent example of this is Esmia, which is ulipristal for the treatment of uterine fibroids. It had previously been associated with the risk of liver injury. We had about 4 cases of liver injury which required liver transplant a few years ago, and that led to some warnings in the product information about this, as well as some advice for liver function monitoring. Unfortunately, at the end of 2018, we had a 5th case of liver failure reported requiring transplant. And in that case, all the measures which had previously been recommended had been followed, which suggested they weren't necessarily effective in all cases. So in March 2020, the license was temporarily suspended while we looked into this further, and the product was recalled to pharmacy level. So if we suspend the license, we have the option to recall the product either from distributors so that no pharmacies get any further supply. We can recall to pharmacy level so that no patients get any further supply, or we can even go as far as to recall it from patients so that patients don't take it at all anymore. In the case of Esmia, it was only given out for very short prescription periods, so in that case, we just record it to pharmacy level. Ultimately, we completed a review of Esmia and decided that actually it was still okay to stay on the market, but the indication was then restricted only to women where surgical procedures were not suitable or had failed. So it has a fairly restricted indication now and is really a last resort option for some women. But the license was reinstated at that point when that decision was made. And there is now a requirement for liver function testing before, during and after treatment. Next slide, please. Just to touch on this as the really nuclear option, where we really feel there is a concern and a risk of harm to patients, and it's not possible to either identify who the most at-risk patients are, or we can't identify feasible risk minimisation actions that will minimise the risk of harm, then we have no option but to revoke the licence. I should say, in my time as a regulator, I can probably count on one hand the number of times that we have had to revoke a licence for a medicine. In many cases, the company will voluntarily decide to withdraw the licence before it gets to that stage, which is what usually happens when you hear about a product being withdrawn for safety reasons. But sometimes it's the regulator that makes that decision. So the example I've included here is for coproximal, which was a painkiller which was quite widely used in the UK, containing dextropropoxyphene as well as paracetamol. Dextropropoxyphene is a very weak opioid, and unfortunately it was associated with lots of fatal overdose cases. So coproximal was responsible for about 300 to 400 UK deaths from overdose every year. This was 18% of all UK drug-related suicides and about 5% of all suicides in the UK. So in 2005, our advisory committee, the Committee on Safety of Medicines, did a review and advised essentially this product should be withdrawn from the market on the grounds that the benefits of taking this drug are not considered to outweigh the risks. It was withdrawn over a long period of 36 months to allow people to find other treatment options, and the Committee on Safety of Medicines issued some treatment guidance to give people some help in terms of choosing alternative treatments. Next slide, please. So turning to expert advice, we as regulators are generally scientists, experts in pharmacovigilance, experts in pharmacoepidemiology, but we're not generally clinicians. And it's very important to have the kind of clinical aspect to consider whether the actions we're thinking of taking are actually likely to minimise risk, if they're feasible, what's really likely to work in practice. So we would generally seek advice from experts when we think there is a significant change to the balance of risk and benefits, and if we are considering either suspending the licence or revoking it, or we're placing some kind of restriction on use of the product, so changing the indication or lowering the dose or limiting who can take the medicine. We may also seek expert advice if we're not sure, if we think that the benefit risk balance is fairly sort of finely balanced and we're not really sure one way or another if it's still positive. Next slide, please. We're also likely to seek advice if it's likely to have a large public health impact. So this is generally medicines where they have widespread use, things like statins that are used in millions of patients. If we think there's going to be a high level of public concern or ministerial concern, so if we're aware that there have been lots of queries about this or lots of interest in Parliament, then we would seek expert advice. If we think that new risk minimisation measures are likely to impact on public health policy or clinical practice because they might restrict which products are available to use, we would seek advice. We may also seek advice where we think the outcome will set an important precedent. And generally, we tend to seek advice for novel therapies, so ATMPs or new technologies or approaches or methodologies. Next slide, please. So in terms of what experts can contribute, very often the experts we have on committees are clinicians, or they are experts in a particular medical field, or even experts in a particular scientific field. We have quite a number of pharmacoepidemiologists on our Pharmacovigilance expert advisory group. They can help us get a better view on the strength of evidence, and they can also advise us on the need for further studies and give us advice on the conduct of those studies or on study protocols. Because many of our experts are clinicians, they can offer insight into use in clinical practice and also what other treatment alternatives are available, and what the impact of a new measure might be on the choices available to patients. They can advise us on the best options for minimising risk and how likely it is that a particular measure that we're thinking of putting into place will minimise risk. When it comes to communications, they can advise us on what the key messages should be and who should be receiving those messages, as well as the best way to communicate. But importantly, they encourage trust in our decision-making process. We as regulators think about things in a very regulatory way, but if we have expert advice, essentially it kind of gives more legitimacy to our decisions and helps people to trust the decisions that we make. Next slide, please. So moving on to implementation, the first blob in the top left-hand corner, I've put that first because really the product information is the cornerstone of all of our regulatory decisions, because that's a legal document. Companies have a legal requirement to keep that updated in line with new information, and most other regulatory actions would follow from a change in the product information. We also publish where we can as much detail as we can in minutes and agendas of the expert committees. When we take issues to committees for advice, we try and be transparent about the advice that we get. We issue communications on safety, and we also try to publish public assessment reports where we can to make sure there is transparency about what we're doing. We may target information to healthcare professionals and patients. We may think it's important to send out a direct healthcare professional communication so that doctors receive a direct letter from the agency, which tells them about new information. We may have public hearings where we invite members of the public to join a discussion about an issue. We might decide there's a need for educational materials or patient alerts or patient alert cards. We will publish risk management plan summaries, and we may also occasionally hold press conferences on a particular issue to make sure that we can correctly inform the press about an emerging safety issue. Next slide, please. Evaluation is also a very important part of what we do. On this slide is essentially the kind of benefit risk life cycle. So we implement measures to maximise benefits and minimise risk, and we try to monitor the effectiveness and collect new data on that where we can. The drug utilisation studies that Craig mentioned are very important for this because they help us determine whether advice that has gone out to healthcare professionals has actually been listened to and followed. And this is a continuous cycle. So we put measures in place, we monitor how well they've worked, and we consider if there is a need for other action, how that's affected the risk-benefit balance, and where we might think there's a need for further action, we can make plans to further minimise risk or characterise it. Next slide, please. So just to finish off with a summary of what I tried to talk about. So the balance of risks and benefits is really a sort of a cornerstone of regulatory decision making. We consider this at the time of licensing, and it's reassessed continually as the product is used in post-marketing use. When new information on risk becomes available, we determine whether there is a need for regulatory action and which action will be most appropriate and likely to minimise harm. We can use either informal or formal methods of decision making, and expert advice can help to inform us of best approaches to maximise benefits and minimise risk, as well as encouraging confidence in the decision making process. And when we take action to maximise benefit and minimise risk, this is actively communicated and is evaluated to assess its impact. And that's all I had to say. I've included some further references if that's of any use to anybody. But I think we're probably ready for questions now.
Well, Craig, Catherine, thank you so much. A huge amount of information for us all there. A lot to take in. There's been a couple of questions that have come through. I think the first one, Craig, came up when you were presenting from Andrew Gray. To what extent does the challenge of defining chronic fatigue syndrome, stroke ME, as a clinical entity, and thus the risk of ascertainment bias when relying on retrospective medical records such as CPRD, hamper the application of these methods? More importantly, for LMICs, where access to electronic health records is unlikely, are there alternative approaches from prospective data collection?
That's a very good question. So I think the first part of that about the challenge with defining chronic fatigue, obviously there's a limited amount of information that you can get from electronic healthcare records. And so I think when we're kind of designing studies, we get input from our experts, our expert committees that Catherine's mentioned about, and in terms of what data we need to look at to kind of be confident that a chronic fatigue syndrome diagnosis is actually that. I mean, there obviously will always be some uncertainty about the sensitivity and specificity in these databases. So, and as well, I think obviously I showed you that we've used a range of different kind of study designs and data sources to try and provide reassurance and address the limitations that each kind of data source has. I think the second question about low and middle income countries and access to electronic healthcare records, it is very, very difficult if there isn't that kind of infrastructure in place. I mean, I think you can perhaps use very kind of crude methods if there is information from kind of published literature, for example, on background rates of disease that you could use as your kind of background expected number. And then you can obviously use, if you have any adverse event reports as you're observed, you could kind of use that. But I suppose that is the limitation of some of these methods, is that it does rely on that infrastructure being in place. I hope that kind of answers that question.
Yeah, thank you, Craig. I think, Catherine, the next question again from Andrew is for yourself. It talks about, for the more interventionist elements of the risk management plan, is there specific enablement in the UK law, or does the MHRA rely on broad requirement that MHRAs comply with conditions of registration? So I think this is really around the legal obligations on the companies to have RMPs.
Yes, that's right, Mick. If the sound's a bit choppy, it's choppy on my end. I hope you can all still hear me. Yes, the elements to assure safe use, which are in the US FDA REMS documents, we do have the equivalent in the UK. Essentially, we can make elements of the risk management plan conditions of the marketing authorization if we feel it's important. So things like restricted access, patients being enrolled in registries, a requirement for formal training before prescriptions can be issued. Those are the kind of elements that not only will be captured in the risk management plan, with an obligation on the company to actually monitor the effectiveness of those, but they're also the kind of elements that would be captured as conditions to the marketing authorisation. So, you know, we would make sure the company was implementing all those activities. So yes, we do have provision in UK law for those types of things.
Thanks, Catherine. And of course, we have a very effective inspectorate as well, which is able to visit and audit companies to ensure that they're meeting all of their regulatory obligations, and we do that very often. The next, I think it's more of a comment than a question from a colleague from Ethiopia, Malako, talking about the harmonization of classification of products, prescription or non-prescription. Malako, don't really see a question there, but it's a great comment about the need for harmonization. If you do have a specific question and want to come back to us, we'd be happy to take that offline. But in the absence of any other questions coming through the Q&A, I'd like to ask participants to complete the poll, as we always ask you to do. And while we're doing that, just a reminder that this session has been recorded, and to notify colleagues to access this recording if they're interested in the areas of benefit risk assessment that we've covered in module 3, particularly around pharmacoepi and regulatory decision making. And again, thank you to Craig and Catherine for your excellent presentations this morning. And just to wish everyone now a good day, and we'll close the session here. Thank you all for your attendance. And again, Craig, Catherine, thank you very much. We'll end now.
Thank you. Bye-bye.